Good evening everyone. Just give me a thumbs up if the audio visual is all okay. Yes, is the audio visual okay? Are you able to see me, hear me, see my pointer here on the board? Well, perfect enough. So if the audio visual is okay, then guys we can just get started. So some top topics, I'll rather put it as hot topics. So people who are gearing up for the NEET PG 2024 exam, I am here specifically to take you through some topics I expect would make a difference in the upcoming NEET PG exam. Perhaps I've chosen the topics that have been repeatedly asked in the previous few years, and perhaps I've chosen the topics that require understanding of some specific concepts that are generally not taught on routine basis, and perhaps knowing them would give you that definite extra edge in case you attend this class and you are attentive. Hello Ravi. So time is less, so without wasting much of time I'll begin with this very simple one. So there's a picture given in front of you. This is thigh and this part is leg, and there seems to be an open injury from where this femur seems to be pointing out. So you have to grade this fracture and specify the grade that would best define this fracture. Yes Ravi. So I suppose that image is right in front of you. You're having a good look at this image, and looking at this image I'm sure you can very well make out that what you're dealing with is an open fracture. Okay. Open fracture, you have a wound that's communicating with the fracture, or in other ways it's draining the fracture hematoma. So you have to classify this fracture out. Okay, so Harshil says 3B, but then Irfan says 3C. Perhaps there is a confusion. So there are contrasting answers. Okay, so people are basically caught up between choice C and choice D. Perhaps I've got it. So at least I'm happy that people are familiar about this fact that there is some kind of a grading you have for open fractures. Well, perhaps I don't think I need to tell you the name at least for this grading, this classification. That's called Gustello-Anderson classification. So that's how we classify open fractures. Now in Gustello-Anderson classification you have grade 1, grade 2, and then the fractures further get classified into grade 3, and grade 3 further gets divided into 3A, 3B and 3C. Now this is a classification that's primarily based on the size of the wound. So in grade 1 what you will find that the wound size would be a puncture wound. It will be like less than 1 centimeter type of a wound. So when you see that puncture type of a wound, that's what is grade 1. When you go to grade 2, the wound size would go between 1 to 10 centimeters. And when you go to grade 3, the wound size would cross 10 centimeters. So this is the simple way by which you would be grading, okay, into grade 1, grade 2 and grade 3. Now this grade 3 further gets categorized into 3A, 3B and 3C. How? Now 3C, you have very well mentioned, Harshil, that what you will find in grade 3C, that additionally there would be a vascular injury apart from a fracture, but very important, a vascular injury requiring a repair. Key point, like radial ulnar artery, only radial artery on, no point of repair, because ulnar can sustain. Getting it? So there should be a vascular injury requiring a repair. That will be grade 3C. Now what about 3A and 3B? In 3A, there is some kind of a soft tissue cover left on the bone. So bone is not naked. Now the nearest most soft tissue cover on the bone is periosteum. So at least periosteum will be intact. But when you go to this grade 3B, so what you find is that even the periosteum gets disrupted. So in a simple way, what I can put it up as that the bone totally becomes visible because there is no soft tissue coverage on the bone, not even periosteum. Clear with that? So you can see the bone, that's 3B, the bone is not visible, there is something hiding the bone, but you find the fracture hematoma coming out, there's a wound nearby a fracture, 3A. So are you guys clear with how to divide fractures into various grades based upon this classification? So if I go over here, it's a big wound, must be more than 10 centimeters, and the bone is visible, it's coming out, but the distal pulses have been mentioned to be intact, so this would best be classified as 3B. So clear with that? So periosteal stripping, absolutely right, is there in 3B, perfect enough. And 3A, the periosteum would be intact, so some kind of a soft tissue coverage will be there on the bone, and the wound size will be near to 10 centimeters. So clear, Harshal, Ravi, Kshitij, Mithu, Hiba, are you guys all clear with this classification? So can I have that thumbs up? You're clear with that? Okay. So basically, the idea behind this classification, this Gustello-Anderson classification, it basically guides you on the treatment part. See, grade 1 and maybe up to grade 2, the fixation methods we use are internal fixation methods. Internal fixation basically means fixing bone with metals placed inside the skin. Like I'll give you an example, using a nail, using a plate. So any metal that will be placed inside the skin is internal fixation. But when you go to higher grades, especially grade 3, the rule book says you should always go with external fixation. No internal fixation is done in these cases where there is heavy contamination because of the risk of infection. So most of the metal implant is placed outside the skin, that is an external fixator. So I hope you guys are clear even with the message. The classification is basically guiding you on the treatment part. So that's Gustello-Anderson classification, by virtue of which you classify open fractures, and this particular fracture I'll simply put it up as grade 3B because of that periosteal stripping. Perfect enough. So you've all warmed up. So I'll move on to another question that requires a little bit of thinking before you answer. Now there's a fracture shown in front of you, and looking at this fracture you have to tell me the likely nerve that is going to be injured in this particular fracture. So the likely nerve injury you expect to be there in case someone has come to you with this particular fracture that's shown in front of you. Yes, please. So what is the likely nerve injury you expect in case someone has come to you with this particular fracture that is shown in front of you? Well, Harshal is expecting PIN, posterior introitious nerve injury. Okay, PIN. So a lot of people for PIN. Come on. People who are answering it as PIN. I think that's what you are doing right now, committing a crime. Criminal to say PIN. No, please, never. Posterior introitious nerve is the continuation of radial nerve in the forearm. So this particular nerve is a nerve in the forearm, and the X-ray that is shown in front of you is an X-ray of arm. So there is no posterior introitious nerve here. So how the hell can it be injured? Clear with that? Now most other people are little dicey between radial nerve and median. That makes sense. See, my preference here for the answer would be radial nerve. I think that is the best answer here, and I'll tell you why. Because this particular fracture that you can see in front of you, I would best put this up as what we call as a Holstein-Lewis fracture. Now Holstein-Lewis is basically fracture of shaft of humerus in the lower third, and that's where this fracture is. In such cases, almost 90% of the cases you will find a radial nerve palsy, and that's perhaps why I've answered that it's radial nerve that's likely to be injured, because this is Holstein-Lewis fracture. Fine. Now people who were answering it as median nerve and AIN, So can you guys help me out, like what diagnosis was in your mind? Like Harry, you answered it as AIN, you typed full AIN. So there must be some kind of a diagnosis in your mind also. Okay, so Harshil says this is supracondylar humerus, so that's why he's answered it as AIN. Okay, well. I'll tell you my opinion here. AIN would be the most common nerve injured when you will be, dealing with supracondylar humerus fracture. Of course. But to call a fracture supracondylar humerus, the fracture line must be crossing through the olecranon fossa of the humerus. So I hope you can very well see the olecranon fossa. That's totally intact. So there is nothing wrong with the fossa. So had this fracture been traveling from this fossa area, this olecranon fossa, it would have been supracondylar humerus, and then the answer would have been anterior interosseous nerve. But since this is a fracture in the lower third of the humerus, it's the radial nerve that is injured. Clear? Clear with that? Okay. Okay, Shakur, you've written spiral groove here. So this is not damaging the spiral groove. The radial nerve travels in the spiral groove like this. So this is the nerve in the spiral groove. So as the nerve comes down here, it wraps around the humerus to travel in front. So this is a fracture somewhere where the nerve is wrapping around the humerus. So a fracture here pulls the nerve. The nerve is taking a U-turn, so it is thought to be tethered in the tissues here and around the bone, as it is wrapping around. So it is the wrapping of the bone around that area, of the nerve around the bone in that area, that leads to this fracture being so common in this zone. It's not the fact that this is a nerve being injured in the spiral groove. The nerve is injured below the spiral groove. Clear with that? Clear with that? Clear with that? Okay. And mind you guys, fracture supracondylar humerus is a fracture in the arm, and anterior interosseous nerve is a nerve in the forearm. So please, there is no AIN in the arm. Still here AIN is getting injured. I'll tell you the reason why. What you have in front of fossa is median nerve. The median nerve gets pulled here because of the fracture. See, this is fracture supracondylar humerus going through this fossa here, olecranon fossa. The distal fragment gets pulled back by the pull of a muscle called triceps, and it is the proximal fragment that goes in front, kinking the median nerve. The median nerve somewhere in the lower forearm is giving here a branch that's called AIN. So as this nerve is pulled, this AIN branch gets pulled. So it is the traction injury that AIN is getting here. So AIN here is getting the traction injury. So that is why AIN is getting injured in supracondylar humerus fracture, not median nerve. So just in case you are asked about the commonest nerve injured in fracture supracondylar humerus, it will be AIN, not median nerve. Median nerve is a mobile nerve. So this pull is very well tolerated by median nerve in supracondylar humerus fracture. It is the AIN that cannot tolerate pull and easily gets injured. Clear with that, guys? So are you guys clear with all this? Okay, and Shaukat, I'll just let you know how to contact me up after this, once this class is over. Okay, I'll let you that way and you can catch me up for your problem also. So clear with that? So are you guys clear with this nerve injury part? Fair enough. Now fracture supracondylar humerus is particularly a fracture that's popularly known for its complications. They complicate your exam, especially NEET PG, time and again. It's been such a hot topic for the NEET PG exam that multiple questions are spanned across its complications. So first let me give you the list. You can have a neurovascular injury, this brachial artery, this AIN, that can be involved. Now this is that fracture that is notorious to go into what you guys very well know as that compartment syndrome. And if you miss the compartment syndrome, the sequelae, the end result of compartment syndrome can result in this fracture. That's called Walkman's ischemic contracture I'm sure you're very well aware of this part also. Then this is that fracture where you can have malunion, fracture uniting in the wrong position, leading to that very very popular deformity in the elbow that you guys know as the gun stock deformity. And this is that fracture we can also find another complication occurring around the elbow, that is myositis ossificans. So please be very clear, okay, with this classification, with this list of complications in fracture supracondylar humerus. They've all been part of the NEET PG exam multiple times. So Shakur, what is the disc-like translucent thing below the triceps? I think you're talking of this small shadow here. It's basically an epiphyseal center. Fracture supracondylar humerus is a fracture. So this particular fracture supracondylar humerus, this is a fracture that you find in children who are under the age of 10 years. So often you find those epiphyseal centers that are not fused properly. Clear with that? So that's basically an epiphyseal center, likely of the the lateral condyle or some other epiphyseal center. Could very well be one of capitulum or trochlea. So it could be a little rotated when that epiphyseal center is visible. Clear with that? Clear with that? So clear with everything till here, guys? Clear with everything till here? So can we just discuss a little bit about this thing also, compartment syndrome? So just copying up a question from the FMG exam, the foreign medical graduate exam, but an excellent question prepared by the examiner. The question was on compartment syndrome because the complications of supracondylar humerus fracture are not just limited to complicate the NEET PG exam, they complicate every pattern of the exam. So nowhere do I want you guys to go unprepared. So you have to tell me the sign that will guide you about the worst prognosis in a patient who's landed up with this compartment syndrome. So perhaps I think you very well understand what is compartment syndrome. There is a fracture around the elbow supracondylar humerus that leads to swelling. It blocks the venous return from the forearm, leading to congestion in the forearm and the hand, leading to increased compartment pressure, generating ischemia. In compartment syndrome, if at all that ischemia occurs, it is actually an ischemia mostly limited to the forearm flexor muscles, and to be specific, the flexor muscle that is predominantly involved is this muscle flexor digitorum profundus, because this is the bulky most flexor with maximum metabolic demands. So ischemia of this muscle flexor digitorum profundus is what we call as compartment syndrome. So you have to tell me the sign that will guide you on worst prognosis. So what I can see, B and B, pulselessness. Okay, so what I can see as the answer of the house is pulselessness. Fair enough. But if you ask me about pulselessness, I think it is the most unreliable of all signs. So you can't just rely on this sign. So this is out. No way. Come on. My answer here would actually be paralysis. And this pain on passive stretch of fingers, I will call it as the diagnostic sign, or I will call it as the first sign that appears and guides you to the diagnosis. So please, why people are getting confused with pulselessness and why it's totally unreliable, let me clear my part to you. So guys, can you help me out that if there has to be ischemia of the flexor digitorum profundus, what is the compartment pressure that generally leads to this ischemia in compartment syndrome? Like if I have to diagnose compartment syndrome, of course I can take help of these clinical signs, all these P's, pain on passive stretch, pulselessness, paresthesias, paralysis, pallor, these P's. But I can also measure the compartment pressure, isn't it? Very good, Harshit. So you've given that exact value, absolutely right. So when the pressure in the compartment rises beyond 30 millimeters of mercury, it can generate FDP ischemia. MCQ, another MCQ, perfect. Now please, this pressure is too less to block the radial and the ulnar arteries. So actually, the ischemia is because of microcirculation compression. I mean compression of the capillaries of muscles. So it's not the radial or the ulnar artery that's compressed and where the flow stops. That can happen in the severest of cases, but that's not the usual scenario. So this is a pressure that generally leads to muscle capillaries getting compressed because they have lower pressure. So that is why pulse may be present till the end and still the patient might be landing up with compartment syndrome. But yes, if there is paralysis, that is death. That means ischemia has happened and paralysis cannot be reversed. So if you are asked about the sign, I will give you the first prognosis. My pick, paralysis. Clear with the reason? Clear with this compartment pressure? And clear with the fact that the ischemia predominantly involves flexor distal profundus. Please look at this. The diagnostic sign, the first sign. Pain on passive stretch of fingers. So the fracture is supracondylar humerus. Fracture at the elbow. You're not touching the elbow. You're moving the fingers and the patient is crying. Because when you're moving the fingers, stretching the fingers, you're stretching this muscle flexor digitorum profundus. So basically, this is that sign that is linked to the FDP ischemia. So that's why I said that this will be diagnostic. So I hope you guys are thoroughly clear with the important clinical signs of compartment syndrome, with the value of different signs, because even they become a part of your question paper at times. So are you guys clear with that? Can I have that thumbs up? And people who are answering it as pulselessness, Harry, clear with that? Priyanka, clear with that? So are you guys, or Harshil, clear with that? So are you guys clear with your mistake? Because again I'm telling you, extremely hot topic, supracondylar humerus fracture. Lot of questions come from that area. Clear with it? Wonderful. Kshitij, Sahil, thank you for giving the thumbs up. Hiba, perfect enough. Now another of my favorite one. Of late I have seen that a lot of pictures of plasters coming in your exams, and you have to interpret things looking at those plasters. Perhaps what my take on it is that somewhere down the line the examiner wants you to be attentive in your clinics also. So he's still trying to make a assessment that whether you attended your clinic properly or not. So sometimes there are plasters being put and you're attentive in the clinic and you're observing what is happening, and only then you tend to get these kind of questions right. So just drawing your attention towards one such question. Yes, glass holding cast. Very nice, Harshil. So you mentioned this is a glass holding cast, and perhaps that's why you're saying this is a scaphoid fracture. So guys, please understand one thing. Why this session? Because I want to discuss with you those questions that generally look simple, but they are not simple. Because this patient is folding the fingers, you think this is a glass holding cast, and you think this is a scaphoid fracture. Big no. If it is a scaphoid cast and you want to hold a glass, the thumb has to be free. The thumb interphalangeal joint has to be free. Only if the thumb interphalangeal joint is free would you be able to hold a glass. You want this person to hold a glass, the thumb is not free. So difficult to hold a glass. So please. This is the scaphoid cast given for scaphoid fracture. And the position that you see over here is glass holding position, but I hope you can see here the thumb interphalangeal joint has been kept free. So this gentleman can fold the fingers and move the thumb and hold the glass. This is glass holding cast. So please, I'll just let you know the rule behind casting, putting up plasters. We call it as the rule of 2. So what's rule of 2? You have to go one joint above the level of fracture, and you have to immobilize one joint below the level of fracture. Got my message? Like please. A scaphoid fracture is a fracture in the wrist. So you immobilize the metacarpopharyngeal joint of the thumb. See, scaphoid will be a bone somewhere here in the wrist, and then here you would be having that metacarpopharyngeal joint. So you have already mobilized that base of thumb joint. Why mobilize this interpharyngeal joint? That should be free. Clear? Like. You are very much familiar about Colles cast and the position you put up in Colles cast. I think you're very much familiar with this position called hand shaking position that you see over here. That palmar flexion and this medial deviation. Now Colles will be a fracture that will be involving this distal radius. So you have already immobilized the carpal bones. So why touch the thumb? So can you see in distal radius fracture the complete thumb is left free? So in a simple way, looking at the joints that have been mobilized, you can make out where is the fracture. So what you see over here, where entire thumb is incorporated, is actually a thumb spica cast, and this could be given up for a Bennett's fracture, a fracture at base of the thumb metacarpal. So if the base of the thumb metacarpal is broken, there is a sense to immobilize the interpharyngeal joint. So what you will find in a thumb spica cast, the complete thumb will be incorporated into the plaster. Getting my message? So complete thumb is incorporated. There is something wrong in the thumb metacarpal. Interpharyngeal joint free. There is something wrong in the wrist, like a scaphoid fracture. Total thumb free. Problem with the distal radius. So are you guys clear with that? So rather than trying to go through those kind of positions, sometimes that can be deceptive. So the extent of the plaster is a far better guide to catch a diagnosis looking at the plasters. So are you guys clear with everything till here? So clear, Hiba? Any of this is possible is not a good solution. As a expert, you have to be clear about what's happening around. Fair enough. Yeah, Virender, it's a PYQ in a sense that actually this picture has been there and this picture has been there, and there have been questions relating to these pictures. Like I'll give you an example. You were asked about the sequence in which you put up a Colles cast. So first you give traction with the hand lying in a position of pronation, and after this you add up palmar flexion, and then you give a medial push, the final medial deviation. So this is the sequence in which, or steps in which, a Colles cast is applied. So the INICET paper, you have to choose the proper order of applying a Colles cast. Getting it? So I mean to say that there have been questions from these areas. The idea is to discuss those topics. Okay, clear, Virender? So this is not a session to discuss PYQs. It's basically a session to talk about those topics that have been the hot burning topics in the previous NEET and the INICET papers, specifically the NEET paper. Okay, so clear with that? So any confusions from the area that has been covered till now, because half of the class is over, 30 minutes gone. So any confusions from the area that's been covered till now? Alright, so you have to tell me the incorrect statement out of the following. So quickly drop in your choices, and no negative marking in my class. You make a mistake over here, just a memory for you. So answer wrongly, but take home a memory. Yes. So can you just guys help me out with the incorrect statement over here? So the incorrect statement over here, yes please. There is Thomas sign in dislocation of lunate is diagnostic. Dislocation is mostly seen on lateral views, is the median nerve that is involved after the dislocation, and lunate would usually dislocate anteriorly, which is incorrect. So please, can I have you guys participating in this particular one? Perhaps I can't see your replies anymore, guys. So you've been all very well attentive, and perhaps answering. Okay, wonderful. So Harshil D, Virender B, again D, lunate usually dislocates anteriorly. Okay, B. No one has been able to hit the help buzzer. Sorry, please. This is the incorrect statement. Oops. This is the incorrect statement. Terry Thomas sign is diagnostic. Please. Terry Thomas sign. Terry Thomas sign. Terry Thomas was a comedian, British comedian, who had that gap in between his incisors, between his two teeth. This is actually a sign that's very different. It is actually a sign of scapholunate ligament rupture. So when the scapholunate ligament is broken, like you see this gap between scapholunate here, because that ligament is ruptured. So this is where you see the Terry Thomas sign. It's nothing to do with a lunate dislocation. Come on. So that is the incorrect statement. But perhaps I will take this opportunity here to take you through even the dislocations at the wrist, because I think you're not just clear about this small topic, which is a PYQ, Varinder. There is dislocations. You may have two types of dislocations at the wrist. One is a lunate dislocation. The second one would be the more common perilunate dislocation. Now what you find in lunate dislocation, that this bone lunate dislocates out of the carpus. So that is the scenario in lunate dislocation. Simple, explanatory. But what you find in perilunate dislocation, it's the other carpal bones, but not lunate, that dislocate out of the carpus. So please, these are those diagrams that will help you understand these x-rays and these dislocations. So when you look at a lateral view, you can see the distal radius, you can see this half moon shaped lunate, and you can see other carpal bones, and everything will be in one line. Now you trace the distal radius, you can't see lunate, this is lunate dislocating. But you can trace the distal radius, you can see lunate, you can't see other carpal bones, this is perilunate dislocation. So I'll just do this job for you. So this is the distal radius here. I'll mark it up for you. I hope you can very well see this bone lunate. I pointed it out for you. This half moon shaped bone lunate. So these must be the other carpal bones. So it is lunate not with the radius. So this is lunate dislocation. But see this distal radius. And see this half moon shaped bone lunate. See these other carpal bones. So lunate is with the radius, but not other carpal bones. So perilunate dislocation. So would you guys be able to pick up both the dislocations from the x-rays? You are clear with the two type of dislocations that there is? Can I have that thumbs up from you guys, please? So are you clear with both these dislocations now in a nice way? So you can see them up. Now this dislocated lunate is looking like a teapot. From there you can pour some tea, maybe a cup of coffee in case you guys are feeling sleepy. So this is an X-ray sign that is popular for a case of lunate dislocation, and that's called the spilled teapot sign, or some people call it as like spilled coffee sign. Same spilled teapot sign or spilled coffee sign. So Terry Thomas sign is diagnostic? No, it is spilled teapot sign that's diagnostic, not Terry Thomas sign. So that was the catch. Dislocation you see on the lateral view you have just seen. Median nerve can be involved, yes. Lunate will dislocate anteriorly, yes. You can see very closely here lunate has gone anterior. So are you guys clear with this topic also? Okay, because again this is a popular topic. It's been there in the INI set, it's been there in the NEET PG exam, and I expect some more questions to come to you from this area. So that's why I even talked of the Terry Thomas sign. So an easy one. But let me see, do you really have the understanding? So there's a fracture seen in front of you in a 3-year-old child. This spiral fracture in the tibia, but the fibula is totally intact. So what you can see is a spiral fracture that's involving the lower tibia. So it's only the tibia that is involved, but the fibula is totally intact. So you have to give me a better name for this injury. So should we call it a toddler's fracture, 3 years age, or should we call it a torus fracture, which is the common fracture pattern you find in children? Or no, it's just a tibia only fracture, fibula is intact? Oh no, this is a green stick fracture pattern that you commonly find in children. Green stick, yes. Okay, Mitu says green stick, Harry says green stick. So perhaps I'm happy that you guys are clear with this term, that there is a very important fracture pattern you find in children that's called green stick. That's good. Okay, Sumit says no, it's tibia only fracture. Yeah, because it's only tibia that's broken. Well, okay. Shiti said it's torus fracture. So no one is again at the answer. No one is hitting the buzzer. They're all sleeping. Toddler's fracture. I think I need to spill some coffee on you guys. This is toddler's fracture. That's how classically we define a toddler's fracture. Please, it's not a green stick fracture. See, children are known for these fracture patterns, torus and green stick, but in the upper limb. You mostly find these fractures in the upper limb. So what do you have in a green stick fracture? Look at this bone. I'm sure you can pick up one cortex of the bone is broken. You can very well see the other cortex intact. So this bone is radius, this is ulna. So one cortex of radius is broken, other is intact. And just like ulna, which is a straight bone, radius is also a straight bone. But I'm sure you can very well pick out in this area that there is some degree of bending of bone that is visible. So this kind of a fracture pattern is what we call as green stick, where one part of the bone is broken, the other one is intact, and this bending of the bone that is appreciable. And now what you have in torus fractures, here what you find is buckling of a single cortex of bone. So if you will notice, one cortex of bone radius is pressed inside, like a buckle of a bag. You press the buckle inside to open a bag. So if you see here also, I hope you can pick up one cortex of radius is like, it's chipped in. So that's what a torus fracture is. Clear with that? And here you have a spiral fracture in the tibia with fibula intact. It's a toddler's fracture because of that twisting of the bone and the plastic nature of the bone. It's only tibia breaking, fibula intact. So clear with that answer? Okay, anyone? In case you are dealing with this green stick fracture, what will be the appropriate treatment for this case? So can you guys help me out with this one? What is the right treatment to be offered to a patient with a green stick fracture? Should you just be applying a plaster of Paris cast? Or should you break the other cortex and then apply the plaster? Because only one cortex is broken, break the other one also. Or should you fix with an intramedullary nail? Or should you fix with something called K-wires, Kirschner wire to sharp wires? Yes. So what is the ideal treatment for this green stick fracture? Okay, Harry says, break the other cortex. So एक तो टूटा हुआ है, दूसरा भी तोड़ दो, then apply a plaster. Harry, you will be amazed to know you are correct. Absolutely right. So this is the ideal treatment that should be given to any patient with a green stick fracture. You should actually be breaking the other cortex also, lining the bone and then giving the plaster. Clear with that? So good evening, Rahul. So hope things clear to you. And since we've talked of children, just letting you know some special traction methods for this fracture of shaft of femur that have been in your papers quite a few times. What you see in this first image is Gallows traction, but what you see in the other image is Bryant's traction. So these are the traction methods useful to treat fracture shaft of femur in children who are under the age of 2 years. So when you're talking of children, I just thought I should talk about these two things also, because small children, these are like popular traction methods we use for them. That was the whole idea. Okay, so a little bit of spine area also, because spinal injury is again important. So again, kind of a PYQ. So not correct about the fracture shown over here. Fracture shown. Yes. The fracture shown. So this is the C2 vertebra, second cervical vertebra, with this odontoid process. So it is the base of the odontoid process that is fractured. This particular area is called the pars, P-A-R-S, pars. So pars of C2 is fractured and vertebra C2 is slipping forwards over C3 vertebra. I am sure you are clear with this term called spondylolisthesis. So what you find in spondylolisthesis, that the upper vertebra would slip forward over a lower vertebra. Like if you see over here, this upper vertebra is slipping forward over this lower vertebra. This is spondylolisthesis. Now spondylolisthesis, you have a fracture involving this area of the bone called pars, and this particular area of the bone is called pars here. So this pars breaks and the upper vertebra slips forward over the lower vertebra. So when the pars breaks, there is a dog like shadow visible at the back. That neck of the dog gets broken. So some people find this injury on the x-rays by picking up what you call as the beheaded Scottish dog sign. So here also you can see this upper vertebra has gone forwards over the lower vertebra. So it's L5 vertebra going forward over S1, and as this vertebra goes forward, this neck of the dog is broken over here. So I hope you can see this dog like shadow and this neck broken over here. So beheaded Scottish dog sign. So this is spondylolisthesis, and something similar is visible over here. The C2 vertebra of pars broken, C2 vertebra slipping forward over C3. So in a simple way, what you can see over here is spondylolisthesis of C2 over C3. So guys, quickly give me first the better name for this injury. Like if I have to better denote or give a better name to this injury, spondylolisthesis of C2 over C3. This is spondylolisthesis of C2 over C3. So what would be the better name I will give to this injury? Yes. Please, what will be the better name I'll give to this injury? Come on. Rahul, Sahil, Hiba, Priyanka, Pallav, Sumit. Yes, please. Harshil. I'm sure you must be knowing the better name for this injury. Okay, no problem. I'll just let you guys know. This is that injury that you read in your forensic classes as that hangman's fracture. So वो जो hangman's fracture forensic classes में पढ़ते थे ना, that was nothing else. That was simply spondylolisthesis of C2 over C3. Clear with that? Clear with that? Clear with that? So guys, you have to tell me the incorrect thing about hangman's fracture. Yes. So what's the incorrect thing about hangman's fracture? Please. Wonderful, Hiba. So you know what is hangman's fracture. Sanjay, you know what's hangman's fracture. Road traffic accidents are the commonest cause. Absolutely right. So that is the incorrect thing. That is the incorrect thing. No, that is not the incorrect thing. That is not the incorrect thing. Hangman's fracture, hanging. Please. Don't do this mistake. The incorrect thing is this. This is the answer. Union always occurs? Yes. This injury is spondylosis of C2 over C3? Yes. Accidents are the commonest cause? Yes. So please, hangman's fracture is a misnomer. It is not the cause of death in hanging. Cause of death in hanging is something different. This is just an injury that was incidentally found in some case of hanging, so it got wrongly labeled as hangman's fracture. It's actually spondylosis of C2 over C3, and there is no mortality because the space available for spinal cord is very good. Space available for cord is high. So no mortality, no morbidity, safe injury. So clear with this misconception? Harry, Sanjay, Hiba, Pallav, Sumit, Rahul, Sahil, are you guys all clear with this? So please don't carry it any further, and I hope you are clear with what is spondylolisthesis also. Perfect enough. So there is a splint shown in front of you. It can be used for all of the following indications except, so where can't you use this particular splint? So I think you're pretty much clear with this splint. The cock-up splint, as you call it. So this cock-up splint will not be ideal for which case? So please let me know. Union means a fracture uniting Hiba. So this fracture will eventually unite this fracture. Okay, the pars area, it unites because vertebra is cancellous bone, very quickly unites. Okay. Sumit says Montilla fracture. Come on, Sumit. axillary crutch, Saturday night palsy are paralysis of radial nerve, and Montedia fracture, PAN palsy, posterior interosseous nerve palsy. They all lead to that wrist drop, finger drop of fingers and wrist. It's VIC where the splint will be of no use, because in VIC you have a flexion contracture. You use a different splint for a contracture. So please, this is the VIC splint, and this VIC splint, Walkman's ischemic contracture splint, is better called a turnbuckle splint. You have a flexion contracture, and by rotating this buckle you can distract and stretch a contracted thing. So if you see this kind of a buckle, it's a turnbuckle splint, you think of VIC. Otherwise, this is a cock-up splint that you give for radial nerve palsy, or sometimes even PAN palsy that may happen in Montedia fractures. Clear with that? Clear with that? And this is a knuckle bender splint. Okay, the knuckle bender splint is basically the splint that's useful for cases of claw hand, and claw hand you find in ulnar nerve palsy. And what you see over here is very popular opponent's splint. This is given for ape thumb, and this would generally be the presenting sign of a case of median nerve palsy. So I hope with this question you are also clear with the classical splints we give for 3 different nerve palsies. What we give in median nerve palsy is the opponent splint, in ulnar nerve palsy is the knuckle bender splint. What we give in the radial nerve palsy is the cock-up splint in radial nerve palsy or PAN palsy. Okay, and in case there is a patient with a Walkman's ischemic contracture, where you have a flexion contracture of the joints will be fixed in flexion, you give turnbuckle splints with these buckles. So you turn these buckles to stretch a contracture. Clear with that? Clear with that, guys? So understood with this part also, you are clear with these splints also. Okay, and when I am talking of splints and braces, nowhere can I end up this class until unless I have spoken of these scoliosis braces. See, scoliosis you very well understand is lateral bending of spine, and lateral bending of the spine which is more than 10 degrees. So there's an angle, and that angle has to be more than 10 degrees to call it scoliosis. Oh, excellent, Sumit, excellent. More than 10 degrees Cobb's angle. Yes, you are right. So when the Cobb's angle is more than 10 degrees, that is when you say it's scoliosis. Excellent, Sumit. But the only thing, you spelled Cobb's in the wrong way. It's C. And looking at you, I was almost about to write K. It's Cobb's angle. Okay. So if this is the scoliotic curve, you draw a line along the topmost vertebra of the curve, a line along the bottommost vertebra of the curve, and then this angle that forms here is what you call as the Cobb's angle between the topmost and the lowermost vertebra. When this angle is more than 10 degree, that patient is a case of scoliosis. This is basically developmental anomaly in the spine. Okay. Thumb spica is different from opponent splint. They are given for different indications. Getting it? And perhaps thumb spica is a plaster, and opponents is a splint, plastic stuff like this. Thumb spica plaster will be stretching over a long area. Clear, Sanjay? Okay. Wooden splint is just a basic splint used to immobilize a fracture temporarily. Okay, that's where you use a wooden splint. Any fracture where you want to go with that transportation, you want to put a temporary splint. Okay, so quickly taking through the braces for scoliosis. So 2 popular braces we give for people with scoliosis: Milwaukee brace, Boston brace. Milwaukee brace is the bulkier brace. Okay, you will find it almost going till the neck. Although it is bulky, it is the better brace because it gives you the better correction. But the bulky thing comes with a lot of trouble, because the wear time that is advised for these braces is almost like 20 hours per day. So something as bulky as this could be troublesome. So when you go to Boston brace, you find a much lower profile, much lighter brace, easy to wear. gives you reasonable correction, मतलब good enough correction दे देता है, even Boston brace. So अगर कोई पूछ ले which is more commonly used brace practically, Boston brace. So please do have a good look at Milwaukee brace and Boston brace. If you ask me about the PYQ, I have put a star on the PYQ. Okay, so PYQ, this picture was there and you were supposed to identify which brace is in front of you. The answer was Milwaukee brace, last year. So please have a good look at Milwaukee brace. So I suppose we are clear with both these braces also. Okay, and one last question before we end up the class. The conditions that are associated with a painless limp. Limp basically means lurching of trunk as you walk. So please, lurching, sway. So sometimes when you walk, the sway of your trunk, that's what's limp. And limp basically means that there is some problem with hip. Hip pathologies are like classically having the symptom limp. So you have to tell me the conditions where you find a painless limp. Okay, so most of the people think both congenital dislocation of hip and Perthes have a painless limp, perhaps great enough. But Harry thinks only in Perthes you have a painless limp. Okay, no problem. See, limp can be painful or painless. The painful category of limp you find either when there is an injury, trauma, or when there is infection. For example, this septic arthritis in the hip, there is some injury in the hip. So these scenarios you will find the limbs would generally be painful. Getting it? Now, when there is no injury, no infection, other categories is where you find the painless category of limb, like these scenarios. Like, what is happening in Perthes disease? You have avascular necrosis that involves the femoral head. But classically in this particular age group, 4 to 10 years, this particular age group only. And perhaps why this age group, I'll tell you. See, you have the profunda femoris artery here. This gives circumflex vessels that wind around the femoral neck. Then branches from this arterial ring formed by the circumflex vessels go up and supply the femoral head. So this is one way in which femoral head receives its blood supply from the profunda femoris artery. Now attached on the head of femur, there is a ligament called ligamentum teres, and running inside the ligamentum teres are also arteries supplying the femoral head, and these are the branches of the obturator artery. So basically hip joint has a dual kind of a supply pattern, little bit from the profunda femoris, little bit from the obturator artery. But please, when you are under the age of 4 years, it is obturator that is the dominant system. When you cross the age of 10 years, it is profunda femoris that mainly takes over. So this is a watershed age where obturator branches are receding and profunda femoris are penetrating. So because of some unknown reason, idiopathic, maybe some minor fall, maybe some minor infection, maybe some synovitis in the hip or whatsoever, maybe a developmental issue, a brief phase comes when this transition is not happening properly. So that brief phase, the blood supply to the head is not there, so this head collapses and becomes flat. It becomes flat like a mushroom, like a mushroom. So some people simply call it as mushroom shaped head. So this is what is basically Perthes disease. So no injury, no trauma, painless limp, developmental issue. Got the message? And a similar developmental issue is developmental dysplasia of the hip, that you guys better know as congenital dislocation of the hip. The problem here is that by development there is a flat acetabulum. Now since the acetabulum is flat, the hip dislocates. hip dislocates, the vascularity of the hip is gone because the ligamentum teres breaks, the obturator system is gone, and young children obturator system is the main system. Now because of this vascularity gone, you find a delayed ossification happening in the femoral head. So this femoral head will be small sized head, and this small sized head will dislocate without any injury, no trauma, no injury, just by itself it will dislocate. So congenital dislocation of the hip, painless, no trauma, no injury, painless. Clear? So I hope you understood the basics behind congenital dislocation of hip and Perthes disease. You can very well see there is no role of infection or role of trauma. So that is why these conditions will have a painless limb. But wherever trauma will be there, some injury will be there, the limb will become painful. So are you guys clear with this much? Can I have the thumbs up till here? यहाँ तक चीज़ें समझ में आ गई हैं. So can I have that thumbs up? Dr. Sanjay, Dr. Harry, Dr. Sumit, Hiba, Pallav, Virender, Kshitij, Mithu, clear with everything? Perfect enough. So quickly tell me, in the treatment of congenital dislocation of hip, we use these abduction splints, these popular abduction splints. So what is the name of the splint I've shown in front of you? A previous year question, PYQ. This particular image where I put up a question mark, this image was there and you were supposed to identify this particular splint you use for cases of congenital dislocation of hip. Quickly give me the answer. Quickly give me the answer so that I know you're familiar with this splint, this abduction splint we use for congenital dislocation of the hip. May I know the answer? This particular picture showing in front of you with that question mark I've put Pavlik harness. Absolutely right. Absolutely right. So this is called a Pavlik harness, an abduction splint we use for cases of congenital dislocation of hip. And what you see in the other image is the von Rosen splint. Absolutely right. So these are popular splints we use for cases of congenital dislocation of hip. And guys, anyone who can tell me the name of this splint, quickly, let me see who is the fastest. Very, very popular for cases of CTV, congenital talipes equinus varus, what you guys might know as clubfoot. This particular very popular splint, PYQ. This image was also there in the NEET PG paper, and you were supposed to pick up the name of the splint. So please quickly have a look at these shoes that are mounted on this iron rod, okay, and tell me how would you like to pronounce this splint. So this is a splint we use for cases of CTV, congenital talipes equinus varus. So you have to quickly give me the name of this particular splint shown right in front of you. Come on, Hiba, Sumit, Pithu, Sanjay, Pallav, Kshitij. Last one, and then this class will be over. Last one, and I'm sure you're going to get it. Very easy, very popular one. So there's a splint shown in front of you. You have two shoes that are mounted on. Yes, absolutely right, Monday. Full marks to you. Absolutely right. So this is what you popularly call as a Dennis Brown splint. Absolutely right. So please have a good look at all these splints, 3 splints. Number of times they have been in various exams, the FMG, NEET PG as well as the INICT. So that's all for this session. Wanted to discuss some high yield areas today. That's what I did. So in case you wish to learn more from me, subscribe to this platform, Unacademy. Okay, so there's a next batch coming up at a very attractive price for you. Then you already have all the recorded lectures, the NEET PG Vitals. So just in case you want to go with a comprehensive course, okay, and please, in case you're not even subscribing for that, at least make sure that you appear for the scholarship test that's coming up. You can get up to 100% assured amount, okay. This free mentorship that will be available from the topmost faculty across the country. 18th of June is the date that you have to lock in. 100 questions, so get set to know about your preparation. And in case you're subscribing to Unacademy, use this referral code to get your 10% off from my side. So that's all for today. Thank you for being attentive, okay. Thank you for the lovely comment, Hiba, and would be looking to have you guys as subscribers on Unacademy preferably. Wish you all the best. Any queries before I close the session, please let me know. Anything not clear to you? Anything else? Well, thank you for the lovely comment, Kshitij. But meanwhile, any queries that's troubling you, please feel free to ask. Okay, so anyways, if there's a query once the class is over, t.me Dr. Mukul Ortho. So this is a Telegram group I run. So you guys can get in touch with me on this Telegram group. You can message me up on Telegram, okay, and I would help you out with the problem that's troubling you. Fair enough? So good night for today. Hope you enjoyed the class. Would catch you up soon. Stay connected with me on Telegram. Bye bye. Good night.